Welcome. In this session, we'll discuss retinal and choroidal circulations. The retina has a dual blood supply, with the inner two-thirds of the retina being supplied by the retinal circulation and the outer avascular one-third of retina, including the retinal pigment epithelium, being supplied by the choroidal circulation. The retinal circulation thus supplies the inner two-thirds of the retina and starts with the central retinal artery, which is the first branch of the ophthalmic artery. The central retinal artery is an end artery with no significant anastomosis with other arteries. The central retinal artery divides into superior and inferior papillary arteries anterior to the lamina cribrosa of the optic nerve head. This superior-inferior division is maintained in the entire retina, as normal retinal vessels rarely cross the horizontal raphe. So the branches of the superior division of the central retinal artery supply the area of the retina superior to the horizontal raphe, and the branches of the inferior division of the central retina supply the area of the retina inferior to the horizontal raphe. And presence of vessels crossing the horizontal raphe is abnormal and suggests them being collaterals following retinal vein occlusion. The superior and inferior divisions of the central retinal artery divide into nasal and temporal quadratic arteries. Almost one-third of all individuals have a cilioretinal artery, and the cilioretinal artery arises from the posterior ciliary arteries and not from the central retinal artery. The cilioretinal artery enters the retina at the temporal margin of the optic nerve head and supplies a portion of the macula. Retinal arteries as well as veins exhibit dichotomous branching, which means that at every branching point the retinal vessel divides into two. The arteries and the veins remain in the nerve fiber layer, as shown here in this diagram, and supply four layers of capillaries. The radial peripapillary capillary plexus lies in the nerve fiber layer around the optic nerve head and is not shown here in this diagram. The superficial capillary plexus lies in the nerve fiber layer and the ganglion cell layer. The intermediate capillary plexus lies in the inner surface of the inner nuclear layer, and the deep capillary plexus lies along the outer surface of the inner nuclear layer. In some descriptions, the intermediate and deep capillary plexuses are considered together as the deep capillary plexus, and these individual capillary plexuses can be separately imaged by optical coherence tomography angiography. Retinal capillaries are absent along the retinal arteries and veins at the ora serrata and at the foveal avascular zone in the center of the retina. If we recall, in the foveal avascular zone, only photoreceptors are present in the retina, and photoreceptors are supplied by the choroidal circulation. Since the inner layers of the retina, which are supplied by the retinal circulation, are absent, the retinal blood vessels are not found in the foveal avascular zone. Retinal capillaries have a luminal diameter of 3 to 6 microns, requiring deformation of red blood cells for the red blood cells to pass through the retinal capillaries. The retinal capillaries have a single layer of endothelial cells with tight junctions between them. These tight junctions form the inner blood-retinal barrier, which is very important to remember. A basement membrane surrounds the endothelium, and retinal glial cells attach to this basement membrane. Pericytes are present between the endothelial cells and the basement membrane, and these pericytes are modified smooth muscle cells. Pericytes support endothelial cells and prevent their proliferation. Pericytes also have a role in autoregulation of blood flow through the retinal vessels, and loss of pericytes is characteristic of diabetic retinopathy, which leads to increased permeability of retinal capillaries and microaneurysm formation in diabetic retinopathy. Fenestrations are not present in retinal capillary bed, and this is very important to remember. So, unlike choriocapillaries, retinal capillaries have tight junctions between the endothelial cells and do not have fenestrations. Retinal venules follow the arterioles, and retinal veins, like retinal arteries, are also present in the nerve fiber layer and are situated posterior to the retinal arteries. The retinal arteries appear narrower and brighter red, and retinal venules appear wider and darker red. Where retinal veins and arteries cross, The two vessels have a common adventitial sheath, and these crossing regions are the most common site for branch retinal vein occlusion. Nasal retina has less arteriovenous crossings as the retinal vessels run straighter in the nasal retina. Retinal veins join to form the central retinal vein, which drains into either the superior or the inferior ophthalmic vein, which finally drains into the cavernous sinus. Spontaneous venous pulsation is a visible rhythmic change in retinal vein diameter just anterior to the lamina cribrosa, which is the site of maximum resistance to retinal venous drainage. And spontaneous venous pulsation is related to the difference between the intraocular pressure and the intracranial pressure. The retinal vein anterior to the lamina cribrosa constricts during systole and dilates during diastole of the cardiac cycle. This is because the choriocapillaris transmits the cardiac pulse to the intraocular pressure, and the intraocular pressure thus compresses the retinal vein during systole. Spontaneous venous pulsation is present in 90% of healthy individuals and disappears with raised intracranial pressure when intracranial pressure rises above the intraocular pressure. So absence of a previously existing or previously documented spontaneous venous pulsation is a sign of raised intracranial pressure. Since 10% of healthy individuals do not have spontaneous venous pulsation, we need to have previous documentation of spontaneous venous pulsation to conclude that absence of spontaneous venous pulsation is due to raised intracranial pressure. Retinal circulation has autoregulatory mechanisms to maintain blood flow and oxygenation in the face of fluctuations of systemic oxygenation. Autoregulation occurs through local changes in the concentration of oxygen, carbon dioxide, pH, and adenosine. Retinal circulation, however, does not have autonomic regulation from the autonomic nervous system. We'll find that in the choriocapillaris there is no autoregulatory mechanism but does have autonomic regulation by the autonomic nervous system. The choroid is predominantly a vascular layer which supplies the retinal pigment epithelium and the outer one-third of the retina. The choroid is thickest in the posterior pole and is thinnest at the ora serrata. The choroid receives blood supply from the posterior ciliary arteries and also from the perforating anterior ciliary arteries. The choroid consists of 5 layers, which from the retinal aspect to the scleral aspect are the Bruch's membrane, 3 layers of choroidal vessels along with intervening choroidal stroma, and suprachoroid, which is a transitional zone between choroid and the sclera. So Bruch's membrane is considered as a part of the choroid, although we have discussed it in the previous session along with retinal pigment epithelium. The choroidal stroma is made up of collagen and elastic fibers and contains numerous very large melanocytes as well as other cells. Choroidal melanomas arise from these melanocytes. The choroidal circulation, as we have mentioned, supplies the outer one-third of the retina, the retinal pigment epithelium, and the choroid itself. The choroidal circulation also drains aqueous humor through the uveoscleral route. The choroidal blood vessels are organized into 3 layers, each of which from the scleral to the retinal aspect branch into and supply the next layer. The outer hallux layer consists of large caliber blood vessels, and these are end arteries. The middle sattler's layer consists of small caliber blood vessels and precapillary arterioles, and they are also end arteries. And inner choriocapillaris layer, which is arranged as a single layer of large capillaries with flattened lumen, and more than one RBC can travel simultaneously through the lumen of choriocapillaris. The choriocapillaris is arranged in a lobular pattern in the center and radially in the periphery. Each arteriole in sattler's layer gives rise to a hexagonal lobule of blood vessels with extensive anastomosis within the lobule. The choriocapillaris is lined with endothelial cells with a basement membrane and pericytes between the endothelial cells and the basement membrane. The basement membrane of the choriocapillaris also forms the outermost layer of the Bruch's membrane, as we have mentioned in the previous session. Unlike retinal capillaries, choriocapillaries have fenestrations, which is important to remember. and these fenestrations allow the passage of solutes and small molecules between the outer retina and the choroid. What is clinically important is that these fenestrations allows passage of fluorescein but does not allow exit of plasma proteins. Since it does not allow exit of plasma proteins, albumin can exert osmotic pressure to draw water from the subretinal space and thus maintain retinal adhesion. And since fenestrations do not allow exit of plasma proteins, fenestrations also restrict escape of indocyanin green, as 98% of indocyanin green is bound to plasma proteins. We'll be discussing about fluorescent angiography and indocyanin green angiography in subsequent sessions. The fenestrations and VEGF receptors are present in the retinal side of the choriocapillaries, and the pericytes are present in the scleral side of the choriocapillaries. VEGF is important to maintain the choriocapillaries under normal circumstances, as we will be discussing. Blood from the choriocapillaries drain into venules, which drain into the ampulla of the vortex veins, which are usually 4 to 5 in number, and exit the eye at or posterior to the equator. The vortex veins drain into the superior and the inferior ophthalmic veins. The choroid has the highest rate of blood flow per unit weight of any tissue in the body, and total choroidal blood flow is said to be 18 times more than that of the retina. The retinal pigment epithelium and the choroid have one of the highest oxygen tension in the body, and the blood draining from the choroid still has a very high oxygen tension. The rapid flow of blood in the choriocapillaries also acts as a heat sink, removing the heat generated by absorption of light. Choroidal blood flow does not have any autoregulatory mechanisms, so it is susceptible to changes in systemic oxygenation. But autonomic regulation of choroidal blood flow exists and is controlled by the cervical sympathetic chain. So unlike retinal circulation, choroidal circulation does not have any autoregulatory mechanisms but is under the control of autonomic nervous system. And as we have mentioned, pulsating intraluminal pressure of the choroidal arteries, which correspond to the cardiac cycle, is transmitted to the pulsation of the intraocular pressure. Blood-retinal barrier is very important to understand, which controls the movement of substances between the vascular lumen of the retinal and choroidal circulations and the retina, and thus maintains the environment of the neural retina. The barrier only allows those substances to pass through which have their transporters on the luminal surface of the capillary endothelium. The blood-retinal barrier is located at two sites. The inner or the vascular blood-retinal barrier is formed by the tight junctions between the endothelial cells of the retinal capillaries, and derangement of the inner blood-retinal barrier results in retinal edema as found in diabetic retinopathy and retinal vein occlusion, and the outer blood-retinal barrier formed by the tight junctions between the retinal pigment epithelial cells. Derangement of the outer blood-retinal barrier results in retinal and/or pigment epithelial detachments as found in age-related macular degeneration, central serous retinopathy, and accelerated hypertension. Now we come to retinal oxygenation, and oxygen levels in various regions of the posterior segment differ. The partial pressure of oxygen in the inner retina is 20 mm of mercury, and in the inner segments of the photoreceptors in the outer retina, the partial pressure of oxygen is 20 mm of mercury in a bright environment, which drops to zero after dark adaptation, and the choroid has a very high partial pressure of oxygen of 70 mm of mercury. Hyperoxia is excessive oxygenation of tissues, which results in vasoobliteration in premature infants and vasoconstriction in adults. Hypoxia is reduced availability of oxygen in the tissues, and tissue hypoxia results in activation of hypoxia inducible factor, which is a transcriptional factor which promotes the expression of a large number of substances which help to cope with hypoxia, such as glycolytic enzymes, glucose transporters, adenosine, and vascular endothelial growth factor. Vascular endothelial growth factor, or VEGF, is produced by various retinal cells such as neurons, glia, endothelium, and pericytes, as well as retinal pigment epithelium. Normal levels of VEGF is important for development of blood vessels, maintenance of choriocapillaries, and inhibiting apoptosis of retinal neurons. Tissue hypoxia stimulates overproduction of VEGF from both the retina and the retinal pigment epithelium, and this results in elevated levels of VEGF, which mediates neovascularization and increased vascular permeability. So VEGF mediates both neovascularization and increased vascular permeability, which is important to remember. VEGF is a superfamily of proteins, and VEGF-A is the most important in inducing ocular neovascularization. Multiple isoforms of VEGF-A exists. VEGF-A stimulates VEGF receptors, which are transmembrane glycoproteins with intracellular domains having tyrosine kinase activity, which stimulates biochemical pathways involved in cellular proliferation, migration, and survival. There are two VEGF receptors, VEGF-R1 and VEGF-R2, and VEGF-R2 is more important in ocular neovascularization. Other factors which are induced by HIF1 include angiopoietin-like 4 and CXCL2. Angiopoietin-like 4 breaks down endothelial cell junctions, and CXCL2 promotes neovascularization, and these are potential sites for future drug candidates. Retina has a dual blood supply, with inner two-thirds of the retina being supplied by retinal circulation and outer one-third being supplied by choroidal circulation. The outer plexiform layer forms the watershed region between these two zones. Retinal circulation is provided by the central retinal artery, which is a branch of the ophthalmic artery. Retinal arteries are an end artery system. The branches of the superior and inferior divisions of the central retinal artery do not cross the horizontal raphe. The main branches lie in the nerve fiber layer. The arteries branch into arterioles and then into four layers of capillaries: peripapillary radial capillary plexus lying in the nerve fiber layer, superficial capillary plexus lying in the nerve fiber and the ganglion cell layers, and the intermediate and deep capillary plexuses lying respectively in the anterior and the posterior aspects of the inner nuclear layer. 30% of individuals have a cilioretinal artery, which arises from the posterior ciliary arteries and supply a part of the macula. Endothelial cells of retinal capillaries have tight junctions between them, forming the inner blood-retinal barrier. Retinal capillaries do not have fenestrations. Retinal capillaries have autoregulatory mechanisms but are not under the control of autonomic nervous system. Retinal capillaries drain into venules, which drain into retinal veins. Retinal veins are located posterior to the retinal arteries, where they cross each other in the retinal nerve fiber layer with a common adventitial sheath around them. The retinal veins drain into the central retinal vein, which drains into the superior or inferior ophthalmic vein. The choroid is primarily a vascular layer, which from anterior to posterior consists of the Bruch's membrane, 3 layers of blood vessels with intervening choroidal stroma, which contains a large number of melanocytes, and the suprachoroid. The 3 layers of vessels are from posterior to anterior, the Holler's layer of large arteries, which branch into the Sattler's layer of medium to small arterioles, which then branch into choriocapillaries. The choriocapillaries is a single layer of capillaries with large flattened lumens. They have an external basement membrane, which is also the innermost layer of the Bruch's membrane. Choriocapillaries have fenestrations in their walls. The endothelial cells of the choriocapillaries do not have tight junctions between them. Choriocapillaries does not have autoregulatory system but are under control of the autonomic nervous system. Outer blood retinal barrier is formed by tight junctions between the retinal pigment epithelial cells. Choriocapillaries drain into venules, which ultimately drain into the vortex veins, which then drain into the superior and inferior ophthalmic veins. Normal levels of VEGF are required for vascular development, maintenance of choriocapillaries, and inhibition of apoptosis of retinal neurons. Elevated levels of VEGF occur when hypoxic retinal cells and retinal pigment epithelium secrete excessive VEGF, and this excessive VEGF is responsible for neovascularization and leakage from capillaries. VEGF-A is the most important among the VEGFs for ocular neovascularization, and VEGF receptor 2 is the more important among the two VEGF receptors for ocular neovascularization. Thank you for listening.